Welcome to the lecture about pregnancy-related morbidity and mortality. First of all, we're going to review the vocabulary so that you understand what it is you're reading in literature. When we talk about the birth rate, we calculate it as the number of births per 1,000 women in the population. It's not really women, it's everybody in the population. Maternal mortality is the number of maternal deaths that occur due to childbirth or pregnancy-related complications. And the time frame is within the first 42 days after delivery. And this again is reported as the number per 100,000. And this would be births. Neonatal mortality is the number of infant deaths per 1,000 live births that occur within that first 28 days of life, which is the neonatal period. And then we go to infant mortality, which is the number of deaths that occur between birth and the first 12 months of life. And this, again, is reported per 1,000 live births. So the CDC defines death of a woman while pregnant or within 1 year of pregnancy termination, regardless of the duration or site of the pregnancy, when developing the statistics. Now, what's excluded in these numbers is when a death occurs due to an accident or some incidental cause, like somebody killed her. So this slide shows the trend of pregnancy-related deaths in the United States. The most recent statistics are reported through 2011. And look at the rise. Why do we see that rise? Well, we can only speculate at this point. Some of the thought is women are entering a pregnancy with chronic medical issues. They're developing these medical issues at an earlier age as well. So we all know that hypertension, diabetes, and heart disease is on the rise. And another issue is that women are waiting later in life to conceive. So when we saw that trend where women are getting pregnant more in their 30s than they were in their 20s, and now they have these medical complications that they're bringing to the pregnancy, that's what's attributing to the increase in the death rate, so we think. It's being researched. So when you look at this slide, also going through 2011, we see that cardiovascular disease, other non-cardiac diseases, infections, and hemorrhage accounting for more than 50% of the pregnancy-related deaths. Those at highest risk are Black women, 42.8 per 100,000 live births. And we compare that to the Caucasian population, which is 12.5 per 100,000. And then when we add all other ethnicities to this, it's 17 per 100,000 live births. So why is it that Black women have the highest risk? Well, when you look at hypertension, diabetes, and cardiovascular diseases in the general population, the Black population has highest incidence. So it's not 100% surprising that these women have the highest risk of perinatal deaths as well, because they have these coming into the pregnancy. The CDC has developed a program called the Perinatal Quality Collaborative. And the whole goal is to reduce maternal morbidity and mortality. And our state is one of the 6 states participating in this. And within our state, 100 hospitals are participating. So these are the goals. And this is what should be what you should be on alert for when you're going into your hospitals. We want to reduce severe maternal morbidity related to preeclampsia. I think in the long run, we do a pretty decent job with this. We know what to do when a woman comes in with preeclampsia, so review all of the information that you learned prior to the midterm about this because it's very important. We want to reduce non-medically indicated deliveries before 39 weeks. This has been implemented over the last 18 months, and it's amazing to see how people are sticking to this guideline. Before that, we had people coming in at 37 weeks because of physician convenience or the patient got tired of being pregnant. Well, what would end up happening is if our dates were off even a week and we ended up having a 36-weeker, that baby might end up going into the neonatal intensive care unit. And remember, those late preterm infants, they have a high neonatal death rate. We also want to improve healthcare response to OB hemorrhage. I mentioned this in lecture, that we need to recognize OB hemorrhage. Some of the blood loss is underreported. You are the nurse in the room. If you suspect a greater than normal blood loss, start weighing all of your chucks, your pads, and towels, anything that's going to absorb the blood. And so if we know that this woman is hemorrhaging, we can immediately take action. So what is the role regarding morbidity and mortality decreases in nursing practice? So first of all, speak up. Don't allow inductions prior to 39 weeks. And as a student, you don't have much longer to be in the student role in OB, but just have your ears open for that conversation that's going on in labor and delivery when somebody tries to sneak a patient in prior to 39 weeks. Provide health education, that preconception planning, the prenatal health education, as well as the postpartum. That is our main job. Teach the patients what to be on alert for, what to do that's right, when to report complications, and when to come in and be taken care of. Perform an accurate health assessment. You want to get that health history and identify risks. We want to do this in the prenatal period, the intrapartum period, as well as the postpartum period. You'd be surprised at how much is missed when physicians and nurse practitioners in the office are quickly going through that routine OB intake or routine prenatal visit, and then you as the nurse just happen to ask the right question and it changes the management. Be prepared for emergencies. Don't become complacent. Believe it or not, you will become very comfortable with your job, no matter where you are. But in the OB setting, especially in postpartum where these women are well, you still need to be on alert for the potential complications. Remember, a woman can still have a seizure because of PIH for up to 2 weeks. She can still have a postpartum hemorrhage. Look at those labs. Be proactive. Become active in your nursing department protocol development. And what this means is you need to keep current about nursing practice. You have to be a lifelong learner. At the end of your nursing school, no matter how many degrees you have, you need to continuously get the journals, read the journals, go online, join organizations, and go to conferences. This is the only way that we are going to improve the quality of the nursing care that we provide. And we are only as good as the worst nurse that's out there. And so you want to be the best. Thanks for listening.